Yeah, if you want to.
Okay. Hi, everyone. Thank you all for coming. My name is Theresa. I am an assistant professor of nursing at West Virginia Wesleyan College, where I teach in the nurse practitioner program. I have a couple of my students here this evening. Thank you guys for coming. I'm also a family nurse practitioner. I work at Buchanan Medical Care, where I do family practice. And I'm a doctoral student at West Virginia University, where I've spent the last 3 years studying substance use disorder. A lot of my patients that I'm taking care of as a family nurse practitioner at Buchanan Medical Care have either substance use disorder, or they have hepatitis C, or some problem that's related to substance use disorder. Or I'm taking care of families or grandchildren that are being raised by grandparents, sometimes great-grandparents. So I think that substance use disorder affects all of us. Tonight for Pitar, prevention, intervention, treatment, and recovery, I'm going to be talking about parallel harm reduction. Is anyone tired of hearing about the numbers that are associated with the opioid crisis? I mean, all of the overdose numbers, all of the numbers, they're so tragic. This is one that means a lot to me. This is a picture of the Vietnam Veterans Memorial Wall in DC. In 2015, drug overdoses killed more Americans than the Vietnam War, and then 2016 came. The Center for Disease Control Prevention shows that 64,000 people died from drug overdoses in 2016, and that number was closer to 58,000 for the Vietnam War. I'm going to talk about some other numbers here for comparison too. How many of you think died of car crashes? Do you think we can even parallel that number? Do you think we can come close to those numbers? In 1972, there were about 55,000 deaths from car crashes, and this was before seatbelts. And I want you to think of seatbelts as harm reduction, because we're going to be talking about harm reduction for substance use disorder. But seatbelts are harm reduction. So in 1972, 55,000 Americans died of car crashes because they didn't have that harm reduction in place. It's one of the reasons we need to get harm reduction in place for substance use disorder. More than 43,000 died due to HIV/AIDS during the epidemic's peak in 1995, so we've topped that. And nearly 40,000 died of guns during the peak of those deaths in 1993. We haven't done much in the way of harm reduction for gun deaths, but there definitely was a peak in 1993. Whatever the status quo is, it's clearly not working. So I want to talk about harm reduction versus criminal justice. Because there's a tendency to treat people that have substance use disorders as just criminals. And we've proven pretty much that the criminal justice system, it shouldn't be our only avenue. There are certainly some people that need to be in the criminal justice system. But the first rule is to do no harm. Harm reduction does no harm. Do you think we can say that about the criminal justice system? What are your guys' thoughts on that? Do you think the criminal justice system has harms itself? Think about when someone is arrested, the criminal record that they're left with. So there's harm in that. It takes away some freedoms that you might have. So harm reduction isn't just blanketly condoning the use of substances, but at the same time, it's not causing harm itself. It's just trying to treat people where they're at. The criminal justice system, on the other hand, it leaves patients with community penalties, imprisonment, parole. All of these things infringe on their rights and their freedoms. Those with records are often left with the inability to find a job or steady legitimate income, and this can lead to illicit means to self-sufficiency and debt repayment. This in turn leads to recidivism rates that land more people back in jail, and this perpetuates a cycle of poverty. We have to break that cycle of poverty. Hundreds of thousands of Americans and their families are victims to that cycle of poverty because of this. So we need to make substance use disorder a public health issue, not just a criminal justice issue. And harm reduction is one part of that. Harm reduction is not a new concept. I really like this picture. It says we should ban life jackets and other flotation devices. They only encourage risky behavior. The only 100% effective way to prevent drowning is total abstinence from going into the water. Does that make sense? Of course not. Does abstinence work for anything? in our experience? Has it historically worked for pregnancy? Says the gynecologist in the room. It doesn't work. So in an idealistic world, then I would say people won't use substances. But we don't live in that world. We live in the real world. So we need to address people where they're at. Let's talk about some other types of harm reduction. We talked about seatbelts, and we know that we've decreased the risk of dying from a car crash because of seatbelts. Bicycle helmets, that's a form of harm reduction. So if you ride a bicycle, we recommend that you wear a helmet every time that you ride a bike, because we want to reduce harm all the time, not just part of the time. It's just like riding in a car, you want to wear your seatbelt all of the time. Those seem pretty benign and sometimes not comparable. So let's think of some behaviors that are a little riskier. What about jumping out of an airplane? It has some risk with it, right? My son jumps out of airplanes. He wears a parachute. That's harm reduction. What about condoms? Do you guys think of condoms as harm reduction? So if you're engaging in sexual behavior, there's risk with that. There's a risk of a sexually transmitted infection. There's a risk of an unwanted pregnancy. So you wear condoms so that you don't have an unwanted pregnancy or a sexually transmitted infection. That's harm reduction. So if you think about the rules that go with harm reduction for condoms, we don't limit how many condoms we give out to patients. If people ask for condoms, we should just give them to them. Would you ever consider limiting how many condoms you give out? Probably not, because then you're not going to be reducing all the harm. But some of the stipulations that come with harm reduction programs have those kind of limits. We're limited on sometimes how many needles we can give out. It doesn't really make sense. We need to give out enough needles. What would be the point in giving out 50% of the needles that you need? Because we haven't really reduced all of the harm. Another thing that we see with harm reduction programs and syringe access programs is sometimes there are requirements that you bring syringes back. It doesn't really make sense to me. I wouldn't ask you to bring a condom back. If I'm giving you condoms to reduce harm, I want you to safely dispose of it. And I prefer the same for syringe access programs. If we're giving out syringes, my hope is eventually that we'll educate enough people that we don't really want them bringing those syringes back. We want to give you containers and teach you how to safely dispose of them. Nobody wants syringes lying around the parks. Nobody wants that on either side of the argument. So this is one way to decrease that. Harm reduction actually decreases that. It doesn't increase it. There's lots of room for education there. I want to talk about harm reduction in the cycle of use and the stages of change. This can be applied to almost any habit. It can be applied to smoking, alcoholism, biting your fingernails, fill in the blank for whatever habit is. There are stages of change. You have pre-contemplation, where you're considering that you might want to stop the habit. You have contemplation, and this is where you're actually starting to think a little bit more seriously. Preparation. This is when you actually have a plan for stopping. So if it's cigarette smoking, you might be setting a date when you want to stop smoking. And then you have the action phase. So this is when you are fully engaged and immersed in stopping whatever behavior that you want to stop. And then you have the maintenance stage. So this is when you might have times when you're craving whatever it was that you were doing, but you're maintaining that and you have certain tools that you're using to maintain that. So harm reduction doesn't work in all phases of this. If you're in the pre-contemplation phase, you're using pretty heavily. If you're in the contemplation phase and even the preparation phase, you're probably still using pretty heavily. So harm reduction doesn't really play a role. Well, harm reduction plays more of a role when you're in those phases because you're not ready to quit. So we need to give harm reduction when you're not mentally ready to make a change in your behavior. This is a point for education for a lot of people because some of the argument is that we should just have people stop using drugs. But there's a thought process, and this is well studied, and this thought process goes on, and sometimes you move back and forth. Sometimes you may make it to the preparation stage, but then you'll backtrack into the contemplation stage. So we need to make sure that we have harm reduction in place until you're actually ready to move forward with decreasing your use or stopping your use. Sometimes we use 12-step programs to decrease harm. Sometimes we use religious programs. Can you guys think of other things that you might use to to help patients break the habit. Shame, that's one that we use a lot. Not very effective, is it? It's like psychological warfare. So we need to just meet patients where they're at and help them to make changes and healthy lifestyles. If they're in the throes of addiction, we just need to decrease the harm that's associated with that. And then when they're in the preparation stage and the action stage, we can bring in things like medication-assisted treatment. And when you're in the maintenance phase, you can do ongoing counseling, you can do ongoing medication-assisted treatment. There's gonna be a lot coming forward with medication-assisted treatment. Hospitals and providers are starting to change their mind on that. There are a lot of providers that were against medication-assisted treatment. There was a lot of medication-assisted treatment programs that were done incorrectly. And we're learning how to get better at that, and you're gonna start seeing more of that in the future. So that we can get patients through pre-contemplation, contemplation, decreasing harm, get them to the action phase. Sometimes that's with detox. We have to maintain patients because we see a lot of relapse and we see a lot of recidivism. So medication-assisted treatment, MAT is going to be a part of that. What does harm reduction prevent? So this is this picture that I used in the first slide, and it's that Vietnam memorial. So it prevents death. In one study, naloxone that was used in 399 events had an 83% reversal when used by bystanders. In another study, there was an 89% reversal rate after bystander or EMS naloxone administration. Can you imagine if we reversed 89% of the overdoses? So think of that number in the 60,000s. Can you imagine if we saved 89% of those lives just because we had access to Narcan, just because harm reduction programs were giving out Narcan to people? So harm reduction saves lives. When you come to a harm reduction program, we provide overdose prevention, recognition, response, education to drug users and their neighbors and friends and families, the service providers who work with them. Harm reduction saves lives. When you come to the harm reduction program in Upshur County, we actually give you Narcan. We don't have the nasal Narcan, we have injectable Narcan. So we give you a little brown bag because it doesn't like light, and there are 2 vials of Narcan in it with 2 syringes. And we tell people that are using to make sure that you tell your family where this is. Make sure everyone knows that you're using and that you have Narcan in case they know they need to use it. Make sure they know how to use it. We give information to every person, and that's made free by a grant. What else does harm reduction prevent? HIV. You probably don't think that we have a lot of HIV in West Virginia, and we don't have a lot as many places, but it's coming. Our hepatitis C rates are already climbing. HIV is climbing too. Syringe access programs are the most effective evidence-based HIV prevention tool for people who use drugs. Let's talk about viral hepatitis. This is what I'm seeing in my practice. Hepatitis is a liver inflammation. It's caused by specific viruses, A, B, C. There are a couple of others, but the common ones are A, B, and C. They attack the liver. Hepatitis A, B, and C are different viruses. They're not different stages of the same virus, and they can't turn into another, although you can be co-infected with more than one virus. We commonly see B and C together. B not so much because a lot of our kids are immunized or vaccinated against hepatitis B. Recently in Upshur County, we had an outbreak of hepatitis A, so we started seeing that a little bit more. Chronic long-term hepatitis can lead to inflammation, scarring, cirrhosis, and liver failure. And another note, HCV, the most common one that we're seeing, sexual transmission is actually rare. There are tiny amounts of HCV present in seminal and vaginal fluids, but mostly this is transmitted through people who use drugs and share needles. So why West Virginia? Recently I went to the Bureau of Public Health's meeting in Flatwoods, and there are a few epidemiologists there, and they were sent from Georgia and Baltimore, because where do you send epidemiologists if you're in the epicenter of the opioid crisis? You send them to West Virginia. And they've actually stationed both of these epidemiologists somewhere close to Huntington. And the reason is because of our rising hepatitis C rates. 2015 CDC data reports that West Virginia has the highest rate of hepatitis B and the second highest rate of hepatitis C in the United States. And I can tell you in my practice, although Upshur County is not really hitting this map that they have right now, I can tell you in my practice, every day that I go to work, I have a patient with hepatitis C, and sometimes a couple. Some signs and symptoms of chronic hepatitis C. You might have, and this is gonna vary between people, so you might have fever, vomiting, pale colored stools, extreme fatigue, unexplained weight loss, headache, yellow eyes, loss of appetite, dark urine, an atrophic rash, a swollen abdomen. And you can see the picture of that healthy liver versus that cirrhotic liver. So our goal with harm reduction is to prevent this from happening or to diagnose it early. The progression of the HCV infection. If you're infected with hepatitis C virus, 15 to 25% of those people will clear that virus. It's just like a cold virus. Sometimes we have the ability to clear that if we have a healthy, functioning immune system. But most people don't clear that virus, and they go on to develop chronic hepatitis C, 75 to 85% of the people. And of that group of people, 60 to 70% will get chronic liver disease. 5 to 20% will develop cirrhosis over the next 20 to 30 years, and 1 to 5% of those will have death from either liver cancer or cirrhosis. The HCV treatment. With a 3-month treatment, over 95% of people infected with chronic hepatitis C can be cured. That seems pretty simple. It's really not that simple. There's a big barrier to getting people diagnosed and to getting them to treatment. So just oral medications now, no more interferon. This means no injections. It's a less complicated regimen, fewer side effects. There's 6 genotypes of hepatitis C, and there are medications specific for each one of these genotypes. Some additional challenges that we have. In West Virginia with Medicaid, patients must have stage 3 or 4 fibrosis before they're covered with these medications. So that means we have to allow those patients to get pretty ill before we actually start taking care of them. We need to have a change in that. The other big barrier is that you must be sober for at least 6 months prior to the treatment. There's a concern that if we treat the patient, then they'll start injecting again in a relapse, and then they'll get reinfected. And that does happen. That causes an ethical dilemma. It costs about $80,000 for one patient to get hepatitis C treatment. So you can understand how those patients are typically on Medicaid, and if they get reinfected and need retreated, it's an $80,000 cost. What are your guys' thoughts on that? Some people say that we shouldn't treat people a second time. Any thoughts on that?
That'd be a hard decision to make.
It's a hard decision to make. My argument about this is I have lots of patients that are hypertensive or diabetics or COPDers that smoke. And I have patients that make some choices that cause these diseases. Sometimes patients need more than one cardiac bypass surgery. You guys know people that have had more than one stent or more than one bypass surgery? For some reason, we have a stigma against people that use drugs and the fact that they may need treatment more than once. But we don't apply that same stigma to people that have other health conditions that they've also made a choice in developing. So type 2 diabetes, almost 100% patient choice. And type 2 diabetes causes hundreds of thousands of dollars of cost to the Medicaid system each year.
And additionally, I wonder if some of these things are a choice. Sometimes addiction is so paramount in the addict's brain that it doesn't seem like a choice at all,
Right.
but it seems like the only option.
Exactly. We need to start thinking of all of these as disease processes, and then everyone just gets treatment. And we don't pick and choose who gets a second treatment or who gets a third treatment, because we do it for other things like heart disease. What do we offer at harm reduction sites? For some people, they think that this is a deep, dark, dirty secret, and it's not. I work on the harm reduction van, and you'd be surprised at the people that come there and the people that work there. One thing we offer is supplies. So this is not all inclusive, and it's not at every harm reduction site, but some examples that you'll find are cookers, syringes in various sizes, cotton. Cotton is really important because cotton is used as a filter. It will filter out particles in glass and any kind of bacteria, viruses. Cotton can actually filter that out. But sometimes patients use old cotton balls. You can actually get a disease called cotton fever. It'll make you pretty sick. So we give cotton, we give tourniquets, we also give health education literature. We give antibiotic ointment. This decreases the risk of bacterial endocarditis. Bacterial endocarditis can come from injecting. And if you get bacterial endocarditis, it can lead to heart valve failure, which is about 50 grand per patient to fix that heart valve. And that also is another ethical dilemma. Some patients will get a heart valve and go back and use again and need another heart valve. But again, we have patients that have cardiac problems and we give them more than one bypass surgery or more than one stent, and they're not subjected to that same stigma that you have if you have substance use disorder. We give out gauze pads, we give out condoms, we give out bleach kits. We hope that patients don't reuse needles and that they have a new needle to use every time. But if you do need to reuse a needle, we'll give out bleach kits. We give out Narcan. We give out a lot of Narcan. What we're mostly seeing now is that methamphetamine is the drug of choice, at least in Upshur County, but it's being laced with fentanyl in some cases. So Narcan still plays a role in that. We give out sharps containers, because no one wants needles on the playground. And a lot of people think that we are creating more needles on the playground by having a harm reduction program. That's not true, that's false information. We're actually decreasing those needles on the playground because we're giving patients sharps containers. We have HIV and HCV rapid testing in our harm reduction program. You can do this as a mouth swab or a finger stick. In Upshur County, we do it as a finger stick. We get results in 2 to 5 minutes. And if you're clean, we encourage you at that point to not share needles, and we give you all the needle supplies that you need so that you don't become infected with HIV or hepatitis. And if you are positive for one of these, we send off blood testing to confirm that test, and then we make the appropriate referrals so you can get treatment. We give out fentanyl test kits. This is new. I've worked the harm reduction program at Buchanan since it started. We just started getting these fentanyl test kits. So basically, once you draw up your medicine, you can take the fentanyl test strip and put it in the cooker, and within 2 minutes, you'll know if your methamphetamine or if your heroin is laced with fentanyl. So what do you do with that information? Actually, you can make an informed choice. You can choose to inject more slowly. You can choose to inject in 2 separate injections. You can choose not to inject. You can choose to change your drug dealer if you don't like what you're getting from that drug dealer, or you've lost your trust with that drug dealer. So this reduces overdoses. What we're finding is patients are actually overdosing because of the fentanyl that's laced within their drugs, and they're not aware of it being there. So this gives power to the patient that's using and can decrease overdose rates. That's one thing that harm reduction is doing a great job at.
Do you think that they listen?
They do. We're getting good feedback from it. We're actually doing a survey when we ask them if they want it, and most of them take it. And then when they come back the next time for the needles, we're asking them if they used it, and they tell us yes. So some more things that we do in harm reduction programs. We give education. We don't want people to reuse needles. So you can look at this needle, the brand new needle, how crisp and pristine it is. And then the needle that's been used once, there's already a little bit of wear and tear on it. The needle that's been used twice, and then the needle that's been used 6 times. So you can see how a patient might get bacterial endocarditis from using a needle like this. So we really don't want patients to reuse their needles. If they have to reuse needles, and sometimes that happens because certain harm reduction programs are limited as to how many needles they can give out. So if you have to reuse a needle, we say rinse it 3 times with water, rinse it 3 times with bleach, then rinse it 3 times with water. It's not going to change the structure of that needle, but it's hopefully going to get rid of some of the bacteria. But you can tell bacteria is going to hide in this needle when it starts to look like that. Some more education. We talk about the hierarchy of injection sites. So on this chart, green is the safe injection areas, yellow is kind of okay, red you should avoid. So just giving patients that information about where it's safe to inject has decreased bacterial endocarditis in cases in other states. And we should definitely learn from what other people have done right instead of just trying our own things. Wound care. We tell patients what to do if they get an infection. Warm the area. This increases circulation. It brings white blood cells to the area. It helps you fight an infection. Using hot compresses or soaks. Elevate it. Let it drain. Don't inject into the site. That's really important. Seek medical care if it hasn't improved within 5 to 7 days. If the lump gets bigger or more painful, if we start seeing red streaks to develop. Go to the ER if you have high chills or rigors or high fever, or if you have chest pains. If the infection looks like it's spreading quickly, these might be signs that you're getting bacterial endocarditis and you need to get treatment pretty quickly for this. So just that little bit of education. And then we also do skin checks. When patients come in to get needles, we ask them if they have any wounds that they want us to look at. Referrals. It is difficult to connect this population to needed services. There are so many barriers. The main barrier is transportation. A lot of our services and referrals aren't local. I'm trying to make a change in that. I'm trying to get more providers in the Upshur County area to feel comfortable with taking care of patients who use drugs. But we can make referrals to detox and drug treatment if it's appropriate. That's not the main thing that they're coming there for. They're coming for a syringe access program, and we need to all realize that and be willing to meet them where they're at. But if they're ready, if they're in that stage, that cycle of change where they're in the action phase and they're ready to get treatment, then we make some detox and drug treatment program referrals. We make medical, dental, and mental health service referrals. We do counseling referrals. We do case management referrals. We do housing referrals. We do the HIV, the HCV testing. We do linkages to all kinds of treatment and care, overdose prevention, risk reduction tools, prevention for non-injectors, safer sex interventions. All of the studies say that for every dollar that we spend in this kind of harm reduction saves $5 to $7 in healthcare costs. So for people that are against harm reduction, sometimes if we can just get them to think about the monetary part of it with Medicaid costs, that might change some minds. Empathy. We care about these patients. We don't treat them poorly. Psychological warfare doesn't work. Shaming doesn't work. You're not going to change a person's behavior because you treat them poorly. And I just want to remind everyone that there are a lot of diseases that we have a choice in. High blood pressure, often diet-related. Heart disease, often diet-related. 90% of what we do is dietary and lifestyle. Only about 10% of it is genetics, even though we sometimes like to blame genetics for things. Colon cancer. The World Health Organization says that meat is a carcinogen. Red meat is the same to colorectal cancer as smoking is to lung cancer. But we still take care of people that have colon cancer. We still take care of COPDers that have lung cancer. We still give multiple bypasses to people that eat poorly. I still give insulin to my diabetics. I don't take it away from them after a year and tell them to get over their disease. We need to realize that this is a disease process. We need to give empathy for people who are struggling. There's a lot of stigma about addiction. I'm actually currently doing a project in the emergency department at Davis Health System, and it's just about empathy and stigma. And it's reminding the caregivers of the emergency department that we're taking care of humans. We're taking care of moms and dads and brothers and sisters and kids. And I know there's a lot of bad things that happen, but we're still taking care of humans. And you are not going to help them by being mean to them. You're not going to help them by stigmatizing them. With education, our opinions are founded in evidence-based medicine, data from valid scholarly sources, and science. Without education, opinions are founded in fear, bias, and prejudice. We need to educate people. We all need to educate people. That's all I have. I'm happy to take any questions, have an open conversation.
I have some questions. I'm a recovering IV drug user. I've used IV for probably about 4 years. And of course, I've been, I haven't done that for 5 years. So, but nothing like this was available here at that time. You couldn't get needles anywhere. They wouldn't sell them to you anywhere. So I reused them. Oh, that picture made me sick. All right, let's just say that. Because 6 was like, that would still be brand new if you ask me.
Exactly.
But, okay, because I've been there and because I know what it's like to be that person, I'm confused about some of the things that you said. Especially, is it true at these sites that they ask a person how many times a day they use, and they literally give them like that many needles for like a month, a whole month?
That is true. The reason that we do that in Upshur County is because the harm reduction van only comes the second Thursday of every month. So we are only getting services to people one time a month for 2 hours a day. And we need to find out how much you're using so that we can cover you with a clean needle each time, every day that you use until we come back to give you more needles.
Well, I guess my question is, all right, I feel like, I don't know, just from how things were when I was using, to thinking that you might hand someone, okay, I'm terrible at math, what's 5 times 30? 150, okay? That you would hand someone 150 needles. I just kind of feel like how an addict is going to be responsible for that, to say, okay, I'm going to use this once and I'm going to throw it away. I have trouble thinking that that's going to happen.
Well, we hope that it happens. By giving them enough needles, we hope that it happens. And we can allow people to pick up for other people. So sometimes we'll have spouses come in, or boyfriend, girlfriend, or I've had a mother-daughter come in. And sometimes somebody will sit in the car and not want to come in. But our hope is, because think of where you're at in that cycle. Not everybody's going to be ready to quit using, so we just need to decrease harm. This is all we're focusing on, is decreasing harm. And if that takes 5 needles a day for the whole month, we're going to give you 5 needles a day for the whole month and hope that you don't reuse.
Yeah, I just can imagine them doing other things, you know, like taking them elsewhere, trading them, I mean.
Well, that's actually still a positive, because that's getting clean needles out,
Right,
and somebody
well,
else is
okay,
still
true,
using
I
the
didn't
clean
think
needle.
about it like that.
Yeah.
That leads to my second question, okay, about this quantity of needles going out is, I was an IV drug user. I always managed to make sure my needles ended up in the trash can, all right? I never, ever, ever just left one lay, all right? And especially because I didn't have I had one. I couldn't leave it lay anywhere. You know what I mean?
Right.
So with having this plethora of needles, and you've already got people who do. I found one in the parking lot of my church. Okay, that was very upsetting to me, because even though I was an IV drug user, I can't comprehend that behavior. I can't comprehend someone leaving a needle out like that, just tossing it out their window. That's hard for me to understand. But if people who don't have this plethora of needles would do that, I mean, I am concerned that they would still just continue to dispose of them that way.
I think when you come to a harm reduction program, you're showing some accountability and some responsibility, because you're coming to get clean needles. And we're having a conversation with these people, and we're sending them home with a needle container and telling them how to use it. So
your point is talking about how the addict isn't responsible with needles.
Yes.
The needles are already out there. At this rate, you're giving out clean needles. So now
Right.
whenever someone finds a needle on the ground, it's not going to be infected with HIV
right.
or hepatitis.
Well, even if it was used once by someone who had it,
But if you have 2,000 needles out there that have been cleaned, you know what I mean? If you reduce the amount of people using dirty needles, you're going to reduce the amount of people that have hepatitis.
That's true.
You'd rather be stabbed with a clean needle than a dirty needle. We're not going to get clean needles out there if we don't hand them out.
We've got to hand out in enough quantity. It's just like handing out condoms. If I only hand out, if you're using 10, but I only give you 5, I haven't really reduced harm. We've got to reduce harm to our maximum ability.
There's actually a lot of peer-reviewed studies too. The World Health Organization compiled 200 studies done over 30 years all around the world, and they all show that these fears are unfounded, that doesn't materialize. I just saw somebody last week who had a 2-liter bottle full of used needles in the trunk of their car.
Yeah.
And I also, former IV drug user, I didn't throw my needles away. They always went in a can or a bottle or something like that. So I think a lot of times when they end up in parks and playgrounds and stuff, what's happening is they may see law enforcement or something like that, and they're worried about that, because in some places they're still criminalizing the possession of it.
Okay.
So then it makes sense for you to throw
I
it.
never thought of that either.
Right.
Because crap, here come the cops.
Right.
So we need to decriminalize it, and we need to give enough to reduce harm until patients are in the cycle where they're ready to do something else about their disease.
Okay, all right, that makes sense to me. Also, I was also infected with hepatitis C, and only God knows how many other people I infected, you know, so I was kind of confused about Upshur County on that
Well,
map.
that was 2015 data,
Oh,
so
okay.
it's hard to get data that's up to date. We're working on better resources to get up to date data. So I'm already seeing a difference from what that 2015 slide showed.
Or if I'm correct, those numbers are only gonna show up if they're diagnosed in the county. So if they're diagnosed somewhere else and then they come here,
Right.
that's not gonna show up in our numbers.
When we diagnose.
Well,
So,
I have been through that cycle of trying to get treatment and being refused because I'm healthy. You know, the insurance company hoping that I just get hit by a bus, you know, before I'm, you know, F4 or whatever. But I also am now cured because my husband and I found information and found a way to obtain medication from India. And I would like to get with you after this,
Okay.
because it's so easy. And because of this information, at least 6 other people that I know have received their treatment and also been cured all over the state of West Virginia. So I would be really excited to
Yeah.
get with you and get out that information. So
I've actually had conversations with my physician about that, and I think it really talks about, it's more about the pharmaceutical industry, because the same drug that's $80,000 to $120,000 here is about $700 over there.
I paid $1,000 for my
Yeah.
3 months of treatment.
It's just the
I've
same
heard
drug,
people
it's just,
talking about it. It's hard for a healthcare provider, you know, we're bound by evidence-based medicine. It's hard for us to recommend something that comes from India. I
Right.
understand that people do it, and I appreciate that you're saying that you're cured. When you come to me as a patient, I'm gonna refer you to WVU.
My doctor, I love him. That's where he is, and together we got it done. He was
So he's
supportive.
actually recommending that people do this?
Yes, ma'am.
Okay, that's good to know.
I'll tell you who it is later.
Okay.
there is actually a pilot program, sure you know about that, Corey Hero, where they're,
I didn't know about that.
oh yeah, it just got extended, where they will, they're trying to show that people aren't really gonna get reinfected, so if you have somebody who's positive and has IV drug use in the last 90 days, they will still treat them with Harvoni, because they're trying to do the research.
Yeah, it's a broken system that we're navigating.
Yeah.
And we need to make changes in it.
The pills from India thing, really, that's a whole different conversation about, it really talks about the value of a human life. And these drug companies are saying, okay, well, the value of a life in somebody in India is $700, but the value of a life in somebody in the United States is $80,000, because it's the same drug, and they're just selling it for different prices in different parts of the world. So, but I'm not an ethicist, but
Oh, it's
you could have fun talking about that all day.
I find it infuriating that they want $100,000 for this treatment, so only rich people can get it, you know?
Or you have to be quite ill.
Yeah, right, dying or rich, you know, no in between.
Yeah, I hate disparity in care.
And if they wait to treat you until you're already sick, there's gonna be a plethora of other issues they're gonna have to deal with. Cancer, you know, cirrhosis, the list is,
It makes sense to treat upstream.